Hello, this is Dr. Morris. I'm continuing the lecture series for Anatomy and Physiology 1. This particular lecture will be about fluid and electrolytes. Fluid and electrolytes are an important part of the human body. We have alluded to electrolytes in previous lectures. We talked about sodium, potassium, calcium, chloride, its composition in the extracellular fluid versus the intracellular fluid is what we'll address specifically today. Let's start with fluid balance. Water is a major component of the human body. Water is the medium in which metabolic reactions and other processes must take place, and water comprises the transportation system of the human body. Without an adequate amount of fluid, cells cannot continue to function and will result in death of the cell. In fluid compartments, 60% of the adult's body weight consists of water. In infants, about 70% consist of water. The elderly and the obese population have a lower proportion of water in their body. The distribution of fluid in the intracellular and extracellular compartments are in the following areas: the intravascular fluid, the interstitial fluid, the cerebral spinal fluid, and transcellular fluid. The movement of water, or fluid loss, occurs in the body through urine, feces, and then insensible loss, each of which we'll describe a little bit more in detail. Now, we have already talked about the way water moves in and out of the cell membrane. Through these same processes, the fluid moves in and out of the various compartments that we've talked about as well. If this is a capillary system, fluid can exist inside in the intravascular space, but maybe also inside each individual cell in the intracellular space. And then there are medians by which fluid will exist outside of the capillary or outside of the vascular space. This is referred to as the interstitial fluid. In the same process by which fluid moves in and out of the cell, we see some similarities by which fluid will move in and out of the intravascular space into the interstitial space. Filtration is one of those processes by which water can move and solutes can move from the bloodstream or from the intravascular space to the interstitial space, typically under pressure referred to as hydrostatic pressure, and we'll discuss that a little more in detail as well. There is also the process of diffusion, again, where solutes contribute to the movement of fluid. Solutes meaning protein, electrolytes, sodium, glucose are the example used in this illustration. But basically, the movement of solutes from areas of high concentration to areas of low concentration. Another process would be the process of osmosis, where you see the movement of water in low solute concentrations in the interstitial fluid to areas of high concentration. That's the process of osmosis, just the opposite of what we see in diffusion. And then there is active transport. This is the movement of solutes, again, solutes referring to electrolytes, sodium, potassium, the movement of solutes using a carrier or an energy from a low concentration in the interstitial fluid to areas of higher concentration. Again, they're using a particular carrier to help move the electrolytes. And again, we'll discuss that more in detail throughout this lecture. So, the mechanisms that help to control fluid balance include the thirst mechanism. This is located in the hypothalamus. Hypothalamus you'll study more in detail when we talk about the nervous system and the endocrine system, but basically this is a portion of the brain that has receptors, osmoreceptors, for cells that sense the internal environment. So these cells can actually sense the concentration of fluids, particularly the solute concentration in particular fluids, to sense the internal environment. There are also hormones that will help control fluid balance. These hormones include antidiuretic hormone, which helps to reabsorb water and prevent the body from losing water, which can change the concentration of the fluid in the human body as well. We'll discuss hormones in more detail in subsequent lectures as well. There are also hormones referred to as aldosterone, which cause the reabsorption of sodium and in essence will also cause the reabsorption of water. And again, these hormones we'll discuss more in the renal system. We'll also discuss these in the endocrine system in Anatomy and Physiology Part 2. Fluid freely moves between compartments by a process referred to as filtration or osmosis. Movement between intravascular compartments and interstitial compartments via capillary membranes with hydrostatic and osmotic pressure. Proteins and electrolytes contribute to osmotic pressure. The hydrostatic pressure at the arteriolar end of the capillary and the hydrostatic pressure, the blood pressure, exceeds the opposing interstitial hydrostatic pressure, the blood plasma colloid osmotic pressure of the blood. Thus, fluid is in turn pushed out of the capillaries into the interstitial compartment. This is hydrostatic pressure. Movement of water through cell membrane depends on differences in osmotic pressure between two compartments. In some cases, excess fluid in extracellular compartment can accumulate. This is referred to as edema. The tonicity or concentration of the solute in the fluid affects the fluid shifts between compartments, including the cells. Types of fluids or excess fluids include isotonic fluids, hypotonic fluids, and hypertonic fluids. Some causes of edema: increased capillary hydrostatic pressure. In other words, increased pressure inside the blood vessel. Hypervolemia can cause this. Kidney failure can cause this. Conditions such as congestive heart failure and another process referred to as ascites, where there is an accumulation of fluid in the abdominal cavity, causes increased pressure in the capillaries, increasing hydrostatic pressure, causing edema. Also, the loss of plasma protein. Remember, plasma proteins add to the solute concentration. If the solution is more concentrated, it will actually attract fluid into the blood vessel. If we lose protein, which is a large solute inside the blood vessel, these include substances such as albumin. If we lose these proteins, then fluid will leak out of the blood vessel into the surrounding interstitial tissue. So low protein states, hypoalbuminemia, where there's low protein levels, malnutrition, malabsorption, excessive sodium levels in the extracellular fluid, again, those fluid components outside the cell, such as in hypertension, kidney disease, or increased aldosterone levels. Obstruction of lymphatic circulation. Now, in the lymphatic system, a significant amount of fluid circulates in the system as well. You're familiar with the circulatory system, where red blood cells and other blood cells in the human body circulate. However, in the lymphatic system, it's more of a fluid medium. And if we obstruct this lymphatic system, then fluid increases in these areas and again are pushed out by hydrostatic pressure into the surrounding tissue areas. Also, increased capillary permeability. Any condition that causes the capillaries to be more permeable, fluid will be lost out into the interstitial medium, thus increasing edema. And then an inflammatory response also increases the inflammatory fluid, leading to edema as well. These slides basically illustrate, and I'm not sure how clear these will present on your screen, but basically just demonstrates what we've talked about: increased hydrostatic pressure as seen in capillaries, the increased pressure forcing water out into the interstitial space, the loss of plasma protein, low capillary osmotic pressure, by which protein typically would attract fluid into the blood vessel. But if we lose protein, then there's nothing holding the fluid in the blood vessel, and it's allowed to leak out into the interstitial areas. Another process, lymphatic obstruction, as we just talked about as well, basically where this vessel is blocked off and fluid cannot freely move. Pressure will begin to build in this capillary, and thus the increased pressure forces fluid out into interstitial spaces, causing edema. And then the final is increased capillary permeability. Basically, the blood vessels themselves, the pores in the blood vessels, open up and allow fluid to leak out into the surrounding interstitial space. All of these conditions can cause edema. Now, what are some of the effects of edema? Are swelling, local area swelling. Now, this does not have to be harmful to the human body, but cosmetically, especially lower extremity edema in the ankles in women, have more of a cosmetic effect. Also, swelling in the ankles of men can have a cosmetic effect and be a little unpleasing, but they don't necessarily have to lead to any significant problems. Pitting edema is one of the effects of edema as well. Pitting edema, basically the accumulation of fluid in the interstitial tissue to a significant degree that if you would place your finger on the area of edema and depress that area with your finger, applying a little gentle pressure, when you remove your finger, there's an imprint of your finger in the tissue. This is pitting edema. There's also increased body weight accordingly, some functional impairments. You may not be able to ambulate as effectively with edema accumulating in lower extremities. There may be some pain associated with edema, impairment of arterial circulation in severe cases of edema, and then some other complications can be inability to put on your dentures or wear the dentures due to edema, inability to wear shoes or clothing because of the increased swelling. Fluid deficit and dehydration. Dehydration refers to insufficient body fluid resulting either from inadequate intake or excessive loss or a combination of the two. Losses are more common and affect the extracellular fluid compartments first. A general guide to extracellular fluid loss: dehydration, mild dehydration, 2% of the loss of body weight, moderate dehydration, about 5% of the loss of body weight, and then severe dehydration, about 8% of the loss of body weight. The effects of dehydration are more significant in infants than in adults because if you remember from previous slides, about 70% of the body weight in infants is from water. Now, a general guide to extracellular fluid loss. Condition: hypovolemia. Vascular compartments rapidly depleted. It affects the brain, the heart, and the kidneys first. Those are vital organs. Water loss may be accompanied by a loss of electrolytes and proteins. Electrolyte loss may affect water balance. A general guide to extracellular fluid loss: hypovolemia. Isotonic dehydration refers to proportionate loss of fluid and electrolytes. In other words, an equal amount of fluid is lost from the intracellular and the extracellular fluid spaces. Isotonic, proportionate fluid loss. Hypotonic dehydration refers to the loss of more electrolytes than water itself. Hypotonic dehydration, again, the loss of more electrolytes than water itself. And then hypertonic dehydration refers to the loss of more fluid than electrolytes, resulting in a hypertonic solution. Hypotonic and hypertonic dehydration may influence the movement of water between the compartments, the intracellular and the extracellular compartments. Some causes of dehydration that can affect the human body include vomiting, diarrhea, excessive sweating, a condition referred to as diabetic ketoacidosis, which will be described more to you in subsequent lectures. But basically in diabetic ketoacidosis, the glucose concentration in the bloodstream is significantly high. With elevated glucose levels, especially elevated glucose levels in the kidneys, it causes fluid to go toward the solute concentration. And in diabetics with ketoacidosis, they get a profound hypertonic dehydration because free fluid is lost through the kidneys because of the increased concentration of glucose. But again, diabetic ketoacidosis will be described to you in much more detail in a subsequent lecture. Insufficient water intake, failure to take adequate amounts of fluid can result in dehydration. The effects of dehydration include decreased interstitial and intravascular volume, dry mucous membranes, decreased skin turgor, lower blood pressure, weak pulse, fatigue, and increase in hematocrit. The hematocrit is a reflection of the total blood volume. And remember, the total blood volume is measured by the number of red blood cells. If we decrease the amount of free fluid that's circulating in the intravascular volume, then proportionally you have more red blood cells than you do fluid. And when the hematocrit is measured, it would be falsely elevated because the fluid is more concentrated. And thus you get an increase in hematocrit relative to the effects of dehydration. So what are some of the compensation responses that we see in the body? Well, increased thirst, increased heart rate, constriction of cutaneous blood vessels to divert more blood and fluid back to vital organs, decreased urinary output. Obviously, with inadequate amounts of fluid, the urinary output would significantly decrease. And then also the increased secretion of antidiuretic hormone. Again, antidiuretic hormone causes the retention or the reabsorption of water. Now, as the brain loses water, you get decreased mental function, confusion, and consciousness. Third spacing. This is a concept that's important to understand. Now, there are fluid deficits and fluid excesses, situations in which fluid shifts out of the bloodstream into the body cavity, or tissue where there is no longer available circulating fluid. In other words, now, third spacing is not edema. Third spacing is in an area where there is no circulating fluid. So in cavities is the primary area where you'll see third spacing. So peritonitis, which is basically inflammation in the peritoneal lining, and causes a significant amount of inflammatory fluid to accumulate inside the abdominal cavity, is an example of third spacing. There are certain conditions in liver cirrhosis when the venous system, which supplies blood to the liver, becomes obstructed because the blood flow cannot pass through a diseased liver. It causes an accumulation of ascites. It's a very common condition that you see in patients who suffer from alcoholic liver cirrhosis or cirrhosis caused from infectious diseases such as hepatitis. But abdominal ascites, which is a form of third spacing, can significantly accumulate in these types of individuals. Now, I will just talk about several key electrolytes for the purposes of this lecture. Now, these are only a few of many electrolytes, but these are the ones in clinical settings that are very important for us to recognize. Sodium is one of them. Sodium is a cation. Again, if you remember to previous lectures, we talked about certain ions having particular charges. Sodium is a primary cation. Diffusion of sodium occurs between vascular and interstitial fluids. Sodium transport across membrane is controlled by the sodium-potassium pump, or the active transport. Sodium exists in the form of salt, sodium chloride, or sodium bicarbonate. Sodium levels in the body are controlled by kidneys and aldosterone. I'm going to skip this slide for now, and I'll readdress this in just a minute. Continuing with sodium imbalances. Now, sodium is important in the maintenance of extracellular fluid volume through the effects of osmotic pressure. Sodium makes up about 90% of the solute in the extracellular fluid, essential for the conduction of nerve impulses. As I go back to this slide, if you remember when we talked about the electrical potential across the cell membrane, as you can see outside the membrane in the when we look at the intracellular and extracellular fluid, we see negative charges line up along the cell membrane on the inside of the cell. On the outside, positive charges will line up. This polarization is the resting state of a semi-permeable membrane. As you can see, sodium is an important electrolyte in the extracellular fluid, We will talk about potassium in just a little bit, where it's an important component in the intracellular medium as well. Now, a point to understand, when we measure these numbers of sodium and electrolytes, chloride in a blood sample in a clinical setting, we are measuring the amount of potassium and sodium that are outside the cell. The measurement is of the concentration outside the cell. If we would measure the potassium concentration inside the cell, you can see where that concentration would be extremely high. So it's an important fact to remember when we're looking at diagnostic studies that relate to lab studies on electrolytes. Also, because there's a resting state in this semi-permeable membrane, the electrolyte, again, sodium being a very important player here, is involved in depolarization. Depolarization is a change in the electrical potential across the membrane. A stimulus has arrived to this particular cell. The stimulus opens up sodium channels, and sodium moves to the inside the cell. So now sodium concentrations inside the cell would change. Repolarization is an impulse that moves along the membrane. Sodium channels close, potassium channels open, allowing potassium to move out. As you can see, there is a balancing of the charges now. Again, both sodium and potassium are cations, and because they are both cations, an exchange takes place. The positive charges are now equalized because potassium moved out of the cell as the sodium moved into the cell. That's the process of repolarization. And then there is a return to the resting potential where all the channels close. The sodium-potassium pump returns sodium outside the cell and potassium inside the cell. Now, the sodium-potassium pump is an example of a mechanism that requires energy, that actively pumps these ions against concentration gradients. Now, not concentration in the sense of the charges are different. Remember, they balance out. But just the number of actual potassiums outside the cell is less than the actual number of potassiums inside the cell. And this is regulated by a sodium-potassium pump. Now, sodium imbalances. To continue on the line of sodium, excessive sweating may result in low serum sodium levels. Proportionally more sodium is lost than water, or if only water is used to replace the loss. In other words, when you sweat heavily, it's very important to maintain electrolyte balance. If you only drink free fluid, not that water isn't good for you and you need the water, but if you do this over prolonged periods of time, then you will replace a disproportionate amount of water versus water and sodium. So you need electrolyte replacement as well. So excessive sweating can result in low serum sodium levels, especially if you lose a significant amount of sodium or if you only replace the sodium loss with free water. Now, the normal sodium level, and you should commit this number to memory, sodium level is between 135 and 145 milliequivalents per deciliter. 135 to 145. This may vary a little bit depending on the reference lab that you are working with in a particular hospital, but that's the general level. Hyponatremia refers to levels below 135. The causes of hyponatremia: loss from excessive sweating, vomiting, and diarrhea, use of certain diuretics combined with low-salt diets, hormonal, sorry about the typo there, the hormonal imbalances such as insufficient aldosterone, adrenal insufficiency. We'll see the importance of the adrenal system in regulating electrolytes when we talk about the endocrine system, and excess anti-diuretic hormone secretion, ADH secretion. And then in the case of patients with renal failures, some of the most difficult electrolyte abnormalities, especially inability to control electrolyte abnormalities, occurs in patients with renal failure. Again, for the purposes of this exam, we won't go into a tremendous amount of detail, but in subsequent lectures, we will discuss some aspects of renal failure in Anatomy Physiology Part 2. We see the effects of hyponatremia because of the electrical potential that's set up across the membrane. If there's low sodium level, then obviously there would be an impairment in nervous system conduction. There would also be fluid imbalances in the compartment because cells are dependent on this electrolyte potential, and sodium being a major player. Subsequently, you would see symptoms of fatigue, muscle cramps, sorry about the typo again, nausea and vomiting. You also see decreased osmotic pressure in the extracellular fluid compartment, decrease in blood pressure. Remember, you see a decrease in blood pressure because sodium attracts water. Inside the blood vessel, and this is in the extracellular, but in the intravascular compartment, again, extracellular, but intravascular compartment, if you have a decrease in the amount of sodium, then you will also have a decrease in the amount of fluid. If there is less fluid inside the blood vessel, the pressure will be low. So thus you'll get a decrease in the blood pressure. The signal of decreased blood pressure sends a signal to the kidneys to secrete more aldosterone, an antidiuretic hormone. So hopefully the body's response to a low blood pressure will cause an increase in fluid retention to the intravascular space and will subsequently increase the blood pressure. You also see in the brain a swelling of brain cells in the absence of sodium. Again, sodium inside the brain cells will allow the swelling not to take place. So in brain cells, hyponatremia is quite important because it causes swelling of the brain cells. So, and subsequently you'll get headaches, weakness, and even seizures for neurological presentations of hyponatremia. Now, another condition, hypernatremia, is elevation in the sodium level. This is usually seen with the ingestion of large amounts of sodium in the absence of proportionate water intake. You also may see hypernatremia in the case of insufficient antidiuretic hormone. In other words, too much fluid is lost, and as a subsequent of that, the intravascular and intracellular space becomes concentrated with sodium in the absence of fluid. So insufficient antidiuretic hormone can be a cause of hypernatremia. Also, the loss of thirst mechanism. You also can get watery diarrhea, which you lose a tremendous amount of free fluid, but maybe not a lot of electrolytes, and also prolonged periods of rapid respiration. Now, respiration, our respiratory center and respiratory system is responsible for a significant amount of insensible perspiration. We'll talk more about insensible perspiration in some subsequent lectures, especially when we talk about the integumentary system, because much of the fluid that we lose is through insensible perspiration. But in the respiratory system, we also have to humidify the dry air that we breathe in. If we're breathing rapidly, we use up a tremendous amount of this fluid. And though this is not actual water loss that we see, over a period of time in prolonged and rapid respiration, you can lose a tremendous amount of free fluid or free water and result in hypernatremia. What are some of the effects? Well, we see fluid shift out of the cells owing just to increased osmotic pressure in interstitial and extracellular fluid. We see weakness, agitation. You get a firm subcutaneous tissue, increased thirst, dry, rough mucous membrane, and decreased urinary output due to antidiuretic hormone. Again, I'm sorry, I don't know whether or not you can actually see this picture on your presentation, but I will just go over it briefly to illustrate some of the movements of these various electrolytes in the system. Again, this illustrates just a low sodium concentration inside the bloodstream where sodium is going to be traveling, low osmotic pressure in the extracellular fluid, water will shift outside into the interstitial space because, again, sodium is what attracts water inside the cell. If there's not much sodium inside the vascular space, inside the capillaries, the venules, or the arterioles, then water will subsequently leak out of the intravascular space into the interstitial space. Now, you see more water will shift into the cell from a low concentration of osmotic pressure. So, in other words, you have a high osmotic pressure inside the cell because the concentration of potassium is high. Potassium is still a solute. So now we'll see water going to an area from low to high osmotic pressure. And so water will then be picked up by the cell, causing the cell to swell. Cells swell, function decreases, and the cell will subsequently rupture. This is what you see happen in the brain cells as a result of low sodium concentration. Another condition involving another electrolyte is referred to as hypokalemia. Now, this is due to potassium or low potassium levels. Hypokalemia typically means low potassium level. Excessive losses can be seen in hypokalemia due to diarrhea, diuresis associated with diuretic drugs, in other words, increased urine production stimulated by the use of particular drugs, diuretic drugs, furosemide, butetamide. These are types of diuretic agents that you may have heard of in the past. You're not responsible for knowing diuretic drugs for the purpose of this lecture, but basically diuretic drugs such as Lasix or Bumax are widely available in clinical settings now. And so diuresis, heavy diuresis, causes the loss of potassium. The presence of excessive aldosterone or glucocorticoids, a condition referred to as Cushing's syndrome, which causes a retention of sodium and the excretion of potassium. And then also dietary intake may be altered, or in the treatment of diabetic ketoacidosis. Now, what does that mean? Again, we'll go into more detail about diabetic ketoacidosis, but in patients who have diabetic ketoacidosis, what happens is the potassium enters into the cell along with glucose. So if you treat a person that has diabetic ketoacidosis, that individual typically has a very high glucose level. You treat diabetic ketoacidosis by giving, number one, insulin to take glucose from outside the cell to inside the cell. And that's the purpose of giving insulin, to get glucose from outside the cell to inside the cell. Now, this may seem like a roundabout story, but potassium will actually move into the cell along with the glucose. So if you give insulin in the treatment of diabetic ketoacidosis, you will actually drive potassium inside the cell. Now, that's important because remember, when I say we check, if you check the potassium level of a given individual, you're checking the concentration of potassium that's outside the cell, that's in the intravascular space. So in treating diabetic ketoacidosis with insulin and with water, you've actually decreased the amount of potassium that's in the intravascular space, and thus the potassium level will drop. The person will become hypokalemic because you have treated the diabetic ketoacidosis. Some of the effects of hypokalemia are low potassium level, increased toxicity to heart muscles. The example are medicines like digitalis. These are given to patients with heart problems or heart arrhythmias. You see increased toxicity with this medication. You also see dysrhythmias. You may also see an interference with the neuromuscular function, since potassium is very important in that membrane potential that we described earlier. It will also interfere with the neuromuscular function, and when we talk about the muscular system, you'll see how important electrolytes are in moving across the neuromuscular junction and function. Paresthesia, decreased digestive tract motility, anorexia, nausea, weakening of the respiratory muscles, shallow respirations, and impaired renal function. Hyperkalemia, elevated potassium levels, you typically see in renal failure. These patients are unable to excrete excess potassium levels due to the non-functioning kidneys, and you see an increased potassium level. You may also see it in deficits of aldosterone. You may also see it with the use of potassium-sparing diuretics. Now, diuretics typically cause the loss of free fluid, but there are electrolytes that typically are lost with these diuretics. However, if an individual is on a specific type of diuretic, a potassium-sparing diuretic, then potassium levels will significantly elevate. There also can be a leakage of intracellular potassium that leads to hyperkalemia, or a displacement of potassium by prolonged and severe acidosis. The effects of elevated potassium level or the effects of hyperkalemia include cardiac dysrhythmia, and when you study the cardiovascular system, you'll see what a normal EKG or a normal electrical activity of the heart is. In that pattern, you're able to measure particular waves. One of the waves is referred to as a T wave, which demonstrates the myocardium, especially the ventricular myocardium, is relaxing, called repolarization. But in patients with elevated potassium levels, you can see what's referred to as peaked T waves. You also can see muscle weakness, fatigue, nausea, and paresthesia. This is going back to the EKG, a pattern that you can see. Typically, the electrical activity of the heart has a particular pattern. This is the T wave, and so if you look at an EKG in an individual that has elevated potassium levels, this becomes peaked and sharp. This is the point where the ventricles can relax, and that's what's referred to as a peaked T wave. This gives you an illustration of how a peaked T wave would look. You can see it's much more sharper. It's not the smooth, rounded complex that you typically would see. Just a brief illustration of the peak T wave, an effect of hyperkalemia. Another electrolyte that's important in our system is calcium, and there can be calcium imbalances. Very important, this is another cation, very important extracellular cation, extracellular, ingested with food, milk products stored in the bone, excreted from the body in urine and feces. Calcium balance is controlled by the parathyroid hormone and calcitonin, influenced by vitamin D and phosphate ion levels. Calcium imbalance refers to calcium and phosphate ions in the extracellular fluid have a reciprocal relationship. Alkalosis, which is an elevation in the pH greater than 7.45, and you are familiar with those numbers from previous lecture. The normal pH in the human body is 7.35 to 7.45. So alkalosis may decrease the number of free calcium ions, causing hypocalcemia. Some of the functions of calcium: it provides structural strength essential for bone and teeth, maintains stability of nerve membranes required for muscle contractions and metabolic processes, enzyme reactions such as those involving blood clotting. Calcium levels below 2.2 millimoles per liter, hypoparathyroidism, malabsorption conditions, deficient serum albumin, increased serum pH, and renal failure. Some of the effects: you get increased permeability and hyperexcitability at nerve membranes. You see spontaneous stimulation of skeletal muscles. You may also see muscle twitching, carpopedal spasms. You'll learn about the carpopedal area regions when we take up the musculoskeletal system. But basically, these are little spasms or little twitching that can occur in the small muscles of the hand and the feet. There are some muscle twitching or signs that you can see. One's referred to as Chvostek's sign. The other is schizophrenia, a little spasms in the face that can be elicited by the tapping of muscles of the face. And then also tetany, generalized muscle tremors, spasms, laryngeal spasms, and then heart contraction may weaken. What causes hypercalcemia? Well, serum calcium levels greater than 2.5 millimoles is what defines hypercalcemia. Uncontrolled release of calcium ions from bones due to certain types of cancers or tumors, neoplasms. Hyperparathyroidism, immobility leading to demineralization, also excessive vitamin D, and also another condition referred to as milk alkali syndrome, where increased milk and antacid intake. Again, we won't go a lot into these disease processes at this time, but in some later subsequent lectures we will discuss that. Hypercalcemia affects depressed neuromuscular activity, muscle weakness, loss of muscle tone, lethargy, stupor, personality changes, anorexia, nausea and vomiting, interfere with the function of antidiuretic hormone, cardiac dysrhythmias, and potential decrease in bone density. And the last electrolyte that I'll just mention briefly is chloride. Chloride is one of the anions that we'll talk about, matches proportional with sodium concentration in the plasma. We also see that it also will bind to potassium as well. But for sodium, it matches it proportionally in concentration in the plasma. Increases or decreasing results in patients' hydration and dehydration. So in high chloride levels, we'll consider conditions of acidosis, metabolic acidosis, or you could also consider respiratory alkalosis. And we'll discuss these conditions in more detail when we talk about specifically about pH balance. Also, low chloride, consider metabolic alkalosis and consider respiratory acidosis. As you can see, just the opposite of what you see above. Again, chloride being a very important anion. This is the lecture series on the electrolytes, and we will continue with subsequent lecture series. Thank you.